Hello and welcome to ventricular ejection, the clinical role of contractility. Join me in a hemodynamic pursuit of excellence. I'm Barbara McLean. I'm a critical care clinical specialist and a hemodynamics expert. And so to begin, always important to start off with the basic principles of hemodynamics evaluation. So we want to remind ourselves and always consider that when we're caring for patients, we must think about the right heart system and the left heart system as two different entities. Certainly they share a wall, certainly they share a sac, and certainly they share circulations. And we talk about three basic measures when we're talking about right and left heart. And as you look at this slide, I just wish to describe to you that if the color is red, that means oxygenated blood. If the color is blue, that means deoxygenated blood. And the black and the gray actually are talking about pressures that can be measured on either side of the heart. So to begin, pressure is a reflection of the compliance of a chamber as it's being filled with volume. And we talk about two types of pressures in the hemodynamic world, the first one being arterial pressure and the second being venous pressure. Arterial pressure represents the resistance of the artery in response to a ventricular ejection. We have both systemic arterial pressure and pulmonary arterial pressure. Venous pressure represents the column of pressure that is generated when the ventricle is filling with volume, and it's profoundly affected by valvular integrity, ventricular compliance, and secondarily to the amount of volume. And of course, we have pulmonary and systemic venous pressures. Stroke volume is our powered by cardiac ejection best measure of blood flow. But we only truly measure stroke volume when we look at the individual pulsatile beat. So when we have arterial waveforms or pulsatility methodology to measure blood flow, we can look at stroke volume. And in this case, we talk about stroke volume as a measure made related to left ventricular ejection, measured in the arterial line or measured with the pulsatile waveform. Cardiac output is also a measure of cardiac ejection, but it's right heart cardiac ejection. Cardiac output is measured with a pulmonary arterial catheter by thermal dilution and looks at temperature change over time. Cardiac output is measured in the pulmonary artery. We can calculate cardiac output from the stroke volume in the systemic artery, that's stroke volume times heart rate, and we can calculate the cardiac output measured in the pulmonary artery by taking the cardiac output and dividing it by heart rate. Very important for us to appreciate and understand these differences and the ways in which they are measured. And finally, we talk about tissue oxygenation, a beautiful thing. The left heart fills with primarily oxygenated blood after blood has passed through the alveolar capillary interface, goes to the pulmonary veins, to the LA and the LV. The LV ejects that blood into the system and we measure it as SaO2, SpO2, which is the pulse oximeter, or PaO2, which is the dissolved oxygen in the arterial blood. The right heart is also mobilizing blood, but the right heart is mobilizing relatively deoxygenated blood, also CO2-rich blood, back to the pulmonary vasculature in order to pick up oxygen and remove CO2. And we use SvO2 or ScVO2, the difference being ScVO2 is measured from the central vein and SvO2 is measured from the pulmonary artery. We measure this to reflect whether or not tissues are utilizing adequate oxygen and whether or not they have appropriate oxygen to utilize. And so we apply that hemodynamics to our basic concepts. Basic concepts. Ventricles must fill in order to eject. Ventricular filling occurs during ventricular diastole, and ventricular diastole is the time when the ventricle is most compliant, most relaxed, and most able to fill. The right ventricle fills with that deoxygenated blood from the systemic capillaries and veins through the right atria. And we measure the response of the right ventricle to the volume of blood that fills it by measuring right atrial pressure, or CVP. Now remember, the biggest factor in the diastolic filling pressure is whether or not the ventricle is compliant. The left ventricle fills with oxygenated blood from the pulmonary capillaries, the pulmonary veins, and ultimately that blood is in the left atria. So capillaries to veins to atria to ventricle. And we look at that pressure column, the response of the ventricle to the volume that fills it, reminding ourselves that compliance is the most significant component by measuring left atrial pressure, which is uncommon in the world today, or by using a reflection of left atrial pressure 4 spaces removed, 4 ways back, LA, pulmonary veins, pulmonary venules, pulmonary capillaries, now in the pulmonary artery, measuring either pulmonary artery diastolic pressure or pulmonary artery occlusion pressure, also known as wedge. When we talk about ventricular ejection, we remember that during systole, ventricles eject against resistance and via contraction, contractility, moving deoxygenated blood into the pulmonary artery, and remember the measure there is SVO2, and that is evaluated by the systolic pressure in the pulmonary artery, the systolic pressure, if you're lucky, in the right ventricle, and by right ventricular cardiac output, which is temperature change over time, known as thermal dilution. And then we measure left-sided ventricular ejection by looking at the oxygenated blood in the aorta and the system, remember our indicator being SaO2, and the systolic pressure which is generated in the systemic artery in direct response to your left ventricular stroke volume. Left ventricle ejects into the systemic artery, we can measure the stroke volume, and we can measure the systolic pressure. And it's always important to remind ourselves about the role and the goal of the measurement known as ejection fraction, which is stroke volume divided by end diastolic volume. So, ejection volume divided by filling volume. That's our ejection fraction. Foreman's way of evaluating ejection fraction is the stroke volume. So just to confirm, when we talk about venous pressure is about veins to atria to ventricle. It reflects ventricular compliance, valvular integrity, and the volume that fills the ventricle. The right side of the heart, because the right ventricle is meek, it's mild, it's thin, it doesn't work as hard as the left ventricle. The pressure column on filling is typically 4 to 8 millimeters of mercury. If we talk about the left ventricle, it's thick, it works harder, it's less compliant. The pressure column generated when the left ventricle fills is known most particularly as pulmonary capillary wedge pressure, or PAD, pulmonary artery diastolic pressure, and is normally around 8 to 12 millimeters of mercury. Then we move to the ejection pressure, ventricular and arterial systolic pressures. Right ventricle ejecting into the pulmonary artery typically generates a pressure of around 20 to 30 millimeters of mercury, and left ventricular ejection into the systemic arteries typically reflects a pressure of 80 to 120 millimeters of mercury in the systolic pressure. And then we come to the diastolic pressure. The diastolic pressure reflecting the tone of the arteries. It's the tone of the arteries which distributes the blood throughout the circuit. The vascular tone of the artery is what mobilizes your blood flow to the ultimate place of meaning, which is the capillaries, gas exchange taking place. We remind ourselves that the best general measure we have for vascular tone is diastolic pressure. In the pulmonary artery, diastolic pressure 8 to 12 to 15, and in the systemic artery, the diastolic pressure 60 to 80. Vascular tone reflected by diastolic pressure. And diastolic pressure ultimately will drive the gradient of blood flow through the whole system and perfusing the cells. So, just in summary, the right heart is a conduit of blood flow through the lungs, receiving deoxygenated blood from the central veins and maintaining a very low pressure system because the right ventricle is compliant. The right ventricle ejects blood into the pulmonary vault to remove CO2 and take up that oxygen. And that pulmonary vault, it's short, and those vessels are very compliant. Not much resistance gathered there. The biggest surface in the pulmonary vault is the capillary surface because that's the network where gas exchange takes place. And the right ventricle contracts to move that filling volume against that pulmonary resistance. Endpoint, lung gas exchange. The left heart, oh boy, that left heart, that big, meaty, muscular left heart, mobilizing blood flow through the system, filling with oxygenated blood from the pulmonary veins. And remember that the left ventricle, even though muscular, has a very low diastolic pressure in the healthy heart. So it's a very low pressure gradient, low pressure column in the pulmonary veins. The left ventricle works much harder because the left ventricle is ejecting blood into a much larger systemic vault with much more arteriolar surface, which is where your high resistance is. And the purpose of that blood flow is to deliver oxygen to the cell and take up waste products such as CO2. The left ventricle contracts to move the filling volume against resistance. So now I just want to say, contractility, moving preload against afterload. All three so incredibly important. So at the bedside, we have lots of discussions almost every day about cardiac output and stroke volume. We might be measuring cardiac output in the pulmonary artery. We might be measuring stroke volume in the systemic artery and calculating cardiac output. But above everything else, what I would like to be sure we remember is that this is the best way for us to evaluate cardiac efficiency and responsiveness. We measure cardiac output in the pulmonary artery. We measure stroke volume in the systemic artery or with pulsatile pressures. And we remind ourselves that those stroke volume measures are our poor man's way of evaluating ventricular efficiency. So lots of what I do at the bedside and what I talk about is, are your ventricles efficient? If I give you volume, they should move it. If they can't move volume, do you need a inotrope? If you can't maintain resistance, do you need a vasopressor? But we have to answer all those questions at the bedside. So I want to remind you, cardiac output is heart rate times stroke volume. But stroke volume is the best bedside indicator of the efficient ventricle. Cardiac output and stroke volume change in direct response to what the tissue needs, in direct response to what the resistance circuitry of the arteries are. And cardiac output is the primary, number one contributor to oxygen delivery. That's the left heart function. The right heart function is the primary contributor to CO2 removal. So without both sides of the heart in tip-top shape, you cannot have normal cellular function, delivery of oxygen, and removal of CO2. Stroke volume and stroke volume index are really important to us. This is what we're resuscitating with volume. This is what we're resuscitating with inotrope. And this is what we are defeating with a vasopressor. Stroke volume is that volume ejected by the ventricle with each beat. So stroke volume basically says that take the volume that fills the ventricle at the end of filling and subtract the volume that remains in the ventricle at the end of ejection. That's your stroke volume. That concept of stroke volume guides us to understanding ejection fraction, which is EDV minus ESV divided by EDV, or more simply, stroke volume divided by EDV, or more simply yet, stroke volume ejection divided by diastolic volume filling. Very straightforward, and something we all must remember, because we've got to maintain an effective ejection fraction if we want blood flow to manage our dynamics of oxygen and CO2 removal to be appropriate and effective for our patients. Normal stroke volume, 60 to 100 mLs per beat, can go all the way up to 200 depending on what's occurring at the bedside and what kind of tissue demands you have. And stroke volume index is the amount of blood ejected per beat, but indexed to the body's surface area. And normally that's 25 to 35 mils per meter to the second power. I would like to remind you, however, always, that the most important function of stroke volume, and the only way to evaluate if stroke volume is adequate, is whether or not your tissues are appropriately oxygenated. That's left heart dynamics. Whether or not you are appropriately removing CO2, that's right heart dynamics. And our goal at the bedside is to achieve a maximal function of both our ventricles. So in this module, we're talking about the final major factor which affects stroke volume, which is ventricular power, the ventricular contractility. Ventricular power, which is work and ejection, which is how we move preload against afterload. I can have a lot of volume and no resistance, but if I don't have power, I can't move blood. Power, work, ejection is what we look at when we talk about stroke volume and cardiac output, which are the best measurements that we have at the bedside to reflect blood flow. Not blood pressure, blood flow. We assume a lot about contractility. We really want to understand it, but our best methodology is, of course, the gold standard of evaluating contractility, which is echocardiogram. That's where we measure the ejection fraction. The ejection fraction actually helps us to evaluate whether or not your ventricles have appropriate power, appropriate contractility, which is also known as inotropy. So in order for me to understand, do I need to administer an inotrope, I must be able to understand ejection fraction. Well, at the bedside, I may be able to do an echocardiogram. I might be able to do it as quickly as possible, but continuous measurements of stroke volume help us to appreciate contractility. If we remember that stroke volume is end diastolic volume minus end systolic volume, and that ejection fraction is that same equation divided by end diastolic volume, that helps us to appreciate that at the bedside we are ever vigilant to assure that our stroke volume reflects what our tissues are asking for. In other words, if your tissues are hypoxic, and that's heralded by a lactic acid level, a base deficit, a decreased sodium bicarb, if your tissues are hypoxic, your stroke volume should be responsive and it should increase. So we have all our normal values here. You don't need me to go over those with you. It's simple to read and you probably already know them. What I want you to appreciate is the concept of manipulation of stroke volume to achieve better blood flow. So I want to remind you that when we talk about the right heart and the left heart, we are talking about different measures and different functions. Cardiac output measured in the pulmonary artery, you can calculate stroke volume by dividing cardiac output by heart rate, is a reflection of your right ventricular ejection, which is about mobilizing blood flow to the lung, to the pulmonary capillary interface to promote gas exchange, removal of CO2 and uptake of oxygen. And that the left ventricle mobilizes its blood flow to the systemic capillary tissue interface to promote oxygen delivery and removal of carbon dioxide. The most important function of the heart is to maintain a stroke volume, hence a cardiac output that delivers blood with maximal delivery opportunity of oxygen to the tissues. And when I talk about oxygen delivery, I want to remind you, number one is the cardiac output. That cardiac output also helps us to return the desaturated hemoglobin back to the alveoli and return metabolism byproducts such as CO2 and other waste products. But very important to appreciate, despite their marriage to each other, the right and left heart are different. Left ventricular ejection fraction in normal physiologic states is always higher than right ventricular ejection fraction. This is incredibly important for us to remember. The left heart is preload sensitive and afterload determined and dependent on its work. That means volume affects it, resistance really affects it, but most importantly, that ventricle must be able to contract, must be able to work in the normal physiologic state. Normal left ventricular ejection fraction, meaning the percent of blood ejected divided by the amount of blood that filled it, is 50 to 75%. And we measure that at the bedside by looking at your stroke volume. But the right ventricular ejection fraction in a normal state is lower than the left ventricular ejection fraction. The left ventricle is not work dependent, so it doesn't provide the same amount of ejection as the left heart does. The right heart is dependent almost solely on volume. It's preload dependent, and it is profoundly sensitive to changes in afterload, the resistance in the pulmonary vault. When you have increased resistance in the pulmonary vault, the right ventricle basically collapses. It doesn't actually work effectively against a high afterload because it doesn't have the potential to change its work like the left ventricle does. It's not work dependent. So in a normal state, in my heart right now, my LVEF is 50 to 75%, and my RVEF is 40 to 50%. And that's implied by cardiac output, pulmonary pressures in the pulmonary artery, the right ventricular pressures, and we can also use a catheter to actually measure right ventricular ejection fraction and right ventricular end diastolic volumes. And I wish to assure you that in critical care, you can not only focus that the left ventricle has failed, but you must always consider that the right ventricle has failed. So again, to have a better understanding of work and contractility, just want to remind you, this is an inherent property of cardiac muscle. It's called inotropy. And you can look above at the visual where you see fibers stretching on filling. And you see some fibers that are thin and some fibers that are thick. Those thin and thick filaments actually must slide across each other in order to make the chamber smaller to generate a pressure so we can open the valve and bolus the blood. Thin and thick filaments depend on calcium, and that calcium is ionized calcium. So one of the main factors that we have to consider is, do we have a normal ionized calcium level at the myocardium in order for thin and thick filaments to contract? The stretch of that fiber, what we're looking at in the left hand on the upper visual, the stretch of that fiber should affect the recoil, which is the contractility, against the resistance. So preload affects contractility, which is against resistance. Strength of the myocardial contraction depends on the status of the myocardium. Is it ischemic or normal? Is it infarcted or normal? Do you have normal calcium? Do you have a normal electrical activation? So many components that we can see and that we cannot see affect contractility. And we have in hemodynamics been evaluating contractility since the beginning of the first hemodynamic evaluations in the very early 1970s. It's a theory, it's a concept, but it's one that can save your patient's life. I like to call contractility heart power. Contractility or heart power is what can move volume against resistance. And when we think we have to assist our patient to increase their contractility, we add agents to support positive inotropy. When we believe the dynamism of the heart is overburdened and not required, we may actually reduce the contractility with a negative inotropic agent. So when we look overall at our idea of how to look at contractility, the simplified method is to look at right heart contractility and cardiac output, to look at left heart contractility and stroke volume index. We can actually do calculations known as work calculations, stroke work indices for each ventricle, left ventricular and right ventricular stroke work index. But for many individuals, this requires a fair amount of invasive monitoring and calculation, and then the interpretation can be very variable. So right now, we're focused on cardiac output and stroke volume. And just reminding ourselves that when contractility decreases, stroke volume decreases. Okay, that's pretty simple. But here's the thing I want you to remember, is that when you give patients a volume challenge or a volume bolus, you only know about contractility if that volume bolus that you administered is converted into an increased stroke volume. Volume load to stroke volume via contractility. It's the best contractile test that could ever be. And by the way, that's not just an idea of Barbara. That is the idea of Frank and Starling and the Frank-Starling curve, which is if I give you volume and you have a contractile ventricle, you should be able to eject your volume out. So when you look at this graph and you see that preload or volume load is on the horizontal axis and stroke volume on the vertical. And you can see that number C is a decreased contractility, letter A is a normal contractility, and letter B is increased contractility. So when you have an increased contractile state, I'm going to give you volume and you should be able to eject it. At the point that you can no longer eject effectively the volume that I've administered, we call that the flat portion of the curve, which means no more volume for this patient because we've reached the point of no return of ventricular stretch to optimal, and anything beyond that will not optimize our patient. We love the relationship between contractility and stroke volume and how it relates and how easy it is for us to use at the bedside, like so. I use your CVP to tell me about your preload, and I use your stroke volume to tell me about your contractility. I'm fine if your CVP is increasing as long as your stroke volume is increasing. If your CVP is increasing and your stroke volume is going down in direct response to volume administration, why then I have to step back and consider you might need an inotrope. And those decisions are only made based on the state of the cell, because if it's hypoxic, we have to act quickly. Contractility changes the shift of the curve, but it does not change the shape. And you can see that across these three curves and those three visuals. At the bedside, we assume an increased contractility when we give you volume and you increase your stroke volume, but at the end, you have less volume in the ventricle. That means you have a high ejection fraction, you're moving fluid forward. That's the contractility-dependent component of accepting volume and ejecting it forwards. Preload dependence means I have to give you volume to improve your stroke volume. And so these concepts, which are critically important in terms of theoretic understanding, are going to be measured in the same way at the bedside, which means I'm going to give you volume and see if your stroke volume increases, and I'm going to look at your cells. Cells are hypoxic, you need more stroke volume, I'm going to give you volume. If I give you volume and your stroke volume doesn't increase, but your cells are hypoxic, I am now going to consider an inotrope. I give you volume if you're a volume responder. I give you volume if you're preload dependent. But if you need enhanced contractility so better work can be performed, giving volume will not improve the outcome. I give you volume, CVP is up, but you are not able to mobilize that blood flow forward. Your tissues are hypoxic. I now say you're contractility dependent, and I'm going to add an inotrope. Okay, so now let's put that into practice. So you're looking at this beautiful table, and what I want you to correlate to is the end diastolic volume, the volume that fills the ventricle, and systolic volume, which is what's left at the end of ejection, the stroke volume, which is what is ejected, and the fractional relationship in these four categories. So normal resting cardiac output, end diastolic volume 120, and systolic 48, stroke volume 72, 60% EF. Same heart, but I gave you volume. Same heart, but I gave you volume. That's the Frank-Starling effect. I've driven your volume up to 150. That made your stroke volume go up to 90, but your EF is still 60% because I didn't really change the contractile property of the heart. I just gave you volume. Number 3, ventricular dysfunction. End diastolic volume 120 and systolic volume 80. Stroke volume is only 40, and that's a 30% EF. And now I apply an inotrope, and your end diastolic volume still 120, but your end systolic volume went down to 60. Your stroke volume is now 60, and you've improved your ejection fraction to around 52%. The inotrope helped you work harder to move your volume. Excellent. So let's apply that Frank-Starling principle to all 3 of our components: afterload, contractility, and preload. Gorgeous, gorgeous. Applying that Frank-Starling principle that helps us to appreciate when we give you volume, we expect stroke volume to go up. When we enhance your contractility, we expect your stroke volume to go up. When we apply vasopressor to increase your afterload, stroke volume will go down. I want to be sure that we appreciate these relationships. So looking at your visual, and on the top part, you'll see afterload down, contractility up, preload up. That correlates to the shift to the left of the stroke volume. And when you look down on the lower side, afterload up, contractility down, preload down, that's cardiac dysfunction. It's always a concept that we should be carrying with us in the understanding of the contractile property of the heart, and applying the Frank-Starling mechanism in the best possible way for the balancing of our interventions to improve the blood flow dynamic, which, remember, endpoint, tissue oxygenation. New perspectives coming into our field and coming into our IC units are a way of evaluating left ventricular function, and that's known as left cardiac power. Left cardiac power is a simple calculation. That calculation actually helps us to look at the relationship of the power of the ventricle in response to the arterial blood pressure and the volume load. It's a calculation that uses classical principles, and this is referred to as CPO. Coming soon to the ICU near you, CPO as a strong hemodynamic predictor of mortality and perhaps a strong predictor of interventional support. And for the right ventricle, Finally, we have something that helps us to evaluate right ventricular power. Now, we can always use right ventricular stroke work index, but the new methodology, which helps us to identify severe RV dysfunction, which means that your focus is now on the RV, requires a PA catheter and is known as PAPI, Pulmonary Artery Pulsatility Index. PAS minus PAD divided by CVP. PAPI is the simplest method to look at right ventricular power in a right ventricular myocardial infarction, a pulmonary embolism, or in a positive pressure-induced method of right ventricular dysfunction. Also, coming soon to you in your ICU. So as we remind ourselves about those three major factors which affect stroke volume, preload, contractility, and afterload, and the fourth, which is quite simple, heart rate. Heart rate times stroke volume giving you the cardiac output. Remind yourself that you have the ability to look at stroke volume, to calculate afterload, and to calculate contractility, and to expect that balancing the intervention of these three, volume, preload, inotrope, contractility, vasopressors or vasodilators, afterload, that we are balancing these three concepts, these three methods, these three measures and calculations to be part of our total platform to evaluate the efficiency of the myocardial structure to provide blood flow to the tissues in order to maintain appropriate oxygenation. So, why do we monitor cardiac output and stroke volume? Because we can, because we should, because it is the major function of the cardiovascular system, the transport of blood, of hemoglobin carrying oxygen to the tissues, the transport of blood, of hemoglobin carrying CO2 to the lungs. The best way for us to evaluate efficiency, responsiveness to volume, to vasopressor, to inotrope, and to generate a plan to improve outcomes for our critically ill patients. Because, as said by Luciano Gattinoni, critically ill patients who are unable to sustain a cardiac index in excess of 2 liters per minute per meter to the second power, despite aggressive therapy, will have a very high chance of mortality. What that means is you get the values you can and manipulate them to the best evidence, and the ultimate best evidence is, does my heart provide appropriate blood flow to sustain my tissues? Thank you very much.